Great. Good afternoon. Yeah, good afternoon, everybody, and thank you for joining today. And also thank you to all the people online. I gather we have over 20 online as well, which is excellent. So my name is Jess Dawson from the Advanced Diagnosis and Therapeutics team, and I'm here this morning to introduce our first speaker, who's Dr. Beatriz Goulao, who has joined us all the way from Aberdeen this morning on the train, and is going to talk to us about her research. So thank you very much for joining us. And we both, John, who's also my co-team, really enjoyed reading your application. So we're looking forward to hearing you speak. Thank you
so much. So hi, thank you for the opportunity to talk today here. This research program, RIPPLE program, is about tackling the biggest global health crisis of our century, climate change. And I propose to do that by developing patient-focused methods and interventions that can help incorporate environmental data into health decision-making. Now, it comes from the perspective that there are urgent decisions that need to be made and tough decisions, and we need to assess trade-offs in the health services in order to decarbonize those health services. And I believe that in order to make that a fair process, we need to involve patients and the public in that decision-making. I'll first tell you a little bit about myself. My background is in nutrition, epidemiology, and biostatistics. And I studied at the University of Lisbon. That's where I come from. Then I moved to Aberdeen in 2014 to work at the Aberdeen Centre for Evaluation, which hosts the clinical trials unit. And I started as a trial statistician. I did a PhD alongside that job. Around the time I finished the PhD, I started this role as lead methodologist in the TRIADS program, which is an implementation science in oral health research program funded by NHS Education for Scotland. More recently, I've been awarded an MRC New Investigator Research Grant in trial methodology, and I have taken the role of interim senior statistician in the clinical trials unit, so I lead the team of statisticians there. I'm also part of the Health and Care Services Delivery Research Funding Board. That means that I get to better understand and contribute to national research strategy. In terms of the types of trials I've been involved in, it's a variety. So I have a lot of work in oral health, but also in neurology, gynecology, and obviously implementation science through the TRIADS link. And in total, I've secured research funding of over 2.5 million, more than 700K as chief investigator. I have published 60 research papers, 17 as a first author. I supervise 6 PhD students at the moment. And this year I've been on a break. Since I came back, I've submitted 3 grant applications worth over 1.5 million, and one of them has chief investigator, which leads me to my research focus. So I am the chief investigator for the patient and public involvement in numerical aspects of trials, which sounds quite unusual. This is really with the focus of making health statistics more relevant to patients, but we need to involve them in the gathering and interpretation of those statistics in order to achieve that. And when I say patient and public involvement in this context, what I mean is that we're developing methods to try to engage patients, large numbers of patients, into health decision-making and diverse groups of patients. So it's about methodological innovation in the field. The largest project at the moment is called Pinpoint, and we've been funded by a number of funders in the UK. Pinpoint is about patient and public involvement in target differences in trials. Target differences are how we calculate sample sizes in clinical trials, so that determine how large a trial we need. The vast majority of trialists believe they should be based on an important difference, but perhaps surprisingly, we actually don't know how to quantify a patient-important difference. So asking directly to patients, does this matter to you? Is it important enough? So that's what Pinpoint aims to address. And I'll give you a very simple example of this. So if you have a trial where patients are randomized to virtual dental checkups versus scale and polish, and your primary outcome is bleeding gums, so you're measuring that at the end, comparing the groups, we need to know what difference we're going to base that trial on to design the trial, calculate the sample size, but also interpret the results. So that's where the target difference comes in. Now, Pinpoint is about developing solutions that are off-the-shelf tools that trialists can come in and just take to adapt to a variety of clinical trials, a variety of outcomes, in order to elicit important differences from patients. And this is just an example because we're still developing the solutions, but it might look like It would be a survey format, so we can engage large groups of patients, and it might be that it presents contextual information about the treatments being compared and patient important difference questions. For example, I would consider taking virtual dental checkups over scale and polish. I reduced my risk of gum inflammation by X%. And then we might want some feedback. So we might collect the first round of answers, feed them back to patients that voted, and ask them, does this change your mind? So this is just an example, a prototype of what it might look like. So in order to provide these solutions, I need to be working at this intersection between quantitative methodology, and in this case, opinion-seeking elicitation methods, and psychology of data. So how do people and patients understand statistics and data so they can answer those questions in a way that then produces valid results and meaningful results that we can use in decision-making? It is also about communicating data for decision-making, because in order to get people through this journey, we need to make sure that we can communicate how important these statistics and methods are and how they will actually impact people's lives at the end of the cycle. So that's my unique perspective. And that's what I believe I'm bringing to the RIPPLE program, because the idea is that I could build on the work that I'm doing already to incorporate environmental data into health decision-making. And I believe that that's important because the NHS alone represents 5% of greenhouse gas emissions in the UK, 40% of the public sector. That's what that means. To put it into perspective, if healthcare were a country, it would be the fifth largest emitter on the planet. So it's quite a big problem. We also know that because there's multiple strategy documents confirming it. So we have NHS England, NHS Scotland, and the UK government committing to meet net zero targets. The National Institute for Health and Care Excellence provides recommendations and clinical guidelines for all sorts of clinical fields in the country. And they said they committed in their strategy to incorporate environmental data into their treatment recommendations. But they also said, highlighted, there's not enough high quality data to do that at the moment. So we need to move past that. The Health Foundation finally looked at patients' perspectives. And what they found was that once aware that this is happening, patients are supportive of decarbonizing health services. However, we don't know how to do it. This is where the RIPPLE research program comes in, because it's about developing solutions in a transdisciplinary way that have the overall aim of developing patient-focused methods and interventions to consider environmental data in health decision-making. It aligns with 3 of the college future themes: advanced diagnostic and therapeutics, because it's about underpinning methodologies for the clinical trials of the future that need to be sustainable. It aligns with planetary health, because it's about sustainable health systems and it's about minimizing human impact in our planet in the context of health services. And it aligns with health inequalities, because we need to be considering inequalities and the potential for exacerbating existing inequalities when we're combining environment and health in our decisions. And just to go back to the earlier example, which I think is quite a simple one to consider, if we were to roll out virtual dental checkups to everyone based on an average effectiveness, we think that they're the same head skin polish on average, and the preferences on average are the same, and we're not exploring any heterogeneous effects, then we might be creating more inequality for people that don't have a laptop, don't have internet access, or don't feel confident using those tools to access services. So this is why it needs to be considered, and it is essential to incorporate it. So how do I plan to address that overall aim? 3 work strands. The first one about gathering useful data in health research. The second one about using data in policy. And then the third one about using that data to inform decision-making. So in the first work strand, what I aim to do is to develop or apply elicitation to involve patients in considering environmental impact of health research. So I've led this review, which is really recent. It's still under review in a journal. And it's about measuring the environmental impact of health interventions in randomized controlled trials. And what we found was that there's a surprisingly low number of RCTs collecting environmental impact. So there's a lot of scope to improve this. But there's also no consensus on outcomes or metrics, which means that the ones that are collecting, we can't compare and combine. So we can't advance the field. We need more collective effort. So this is the NIHR research cycle, and thinking about it and thinking about their philosophy of patient and public involvement throughout the cycle, The idea would be to find smart and efficient ways to collect environmental data that actually is relevant for decision making. So we don't want to be collecting data that's unnecessary, and we need to involve the right stakeholders in order to make those decisions at the planning stage. So I'll give you an example. Preliminary data as part of this program would be, for example, related to prioritizing topics. So in what clinical context, what clinical questions is it relevant to consider environmental impact? Because there will be some that are much more controversial and some that are urgent and we could be addressing right now. So we need a collective effort, a framework to prioritize those questions. And I think that's one of the first steps in addressing the problem. Another example that I'll give is that we need to be looking at the wider picture. So it's not just about health services, decarbonizing. We also need to be thinking about how to make our trials and health research smarter and greener. So more efficient, but also more carbon friendly. But throughout everything that I'm saying, we need to take into account trade-offs. We might have a really cool carbon-friendly trial. If it doesn't recruit patients, then what's the point? So we need to be weighting those in. So to address part of that last question, a smaller group of us in the Greener Trials Initiative from the Trials Methodology Research Partnership have been awarded a Wellcome Trust funding to do that work. Here at the university, and I can see a lot of familiar faces that I've spoken to prepare for this application, there's clear overlap of interests and potential to use case studies of a lot of the great research you're doing. So Glasgow CTU Centre of Excellence for Trials Collaboration, Professor John Petrie, Professor Rod Taylor, and here the Digital Health Validation Lab, which I know is linked to HETA, and I've worked with HETA to develop this proposal, so particularly with Professors Olivia Wu and David McAllister. And in global health, with Professor Peter McPherson, there's a lot of potential there too, to use elicitation to make the research cycle more efficient in lower and middle income countries. So this is really what Work Strand 1 is about. Just an example, again, this is quite simple, but I think it makes the point of trade-offs. So we compare the virtual dental checkups versus scale and polishes, and no difference in bleeding gums, so no difference in clinical effectiveness, same carbon footprint. We ask patients, would you get virtual dental checkups in this scenario? And they'll go, if they go yes, they probably would always take it. If they go no, we might start changing. So what if it was 10% lower carbon footprint? What if it was 20%? So you can see how you start looking at trade-offs and when do people switch their decision. And this could inform the design of trials, the prioritization of topics. So using data in policy, this work strand is about developing or expanding methodology to involve patients in appraising health interventions with environmental data. It's in the context of health technology assessments, but those decision-making processes happen all over the world. There's already a strategy to make decisions in health technology assessment, but it doesn't account for the complexity of the decisions we're having to make today. And as I said, these are tough decisions. Candidate methods to do this, so this is just an example, are multi-criteria decision analysis, which is well accepted but underused. It has not yet been adapted to incorporate environmental impact, and it has a lot of potential for patient and public involvement and to strengthen that, maximize the value of the method. It also allows exploring trade-offs across different patient groups, which is one of the goals here, as I said before. So heterogeneity of preferences in virtual dental checkups, as an example. So just to show you what it looks like for those that don't know, this is about the multi-criteria decision analysis. We'd be looking at different outcomes that matter to people in terms of treatment recommendation. And we would elicit that as part of the exercise. And then we would be thinking about, well, how much do they matter in terms of the final decision? And we would be speaking to stakeholders in order to inform that. We aggregate data to then make a final recommendation. And you can see how important it is to get patients involved, but also to make sure that the method is valid for them, that they understand that they follow everything, and to incorporate environmental impacts. It's going to be the future. HETA obviously is very well aligned with this whole research agenda. And finally, I'm aware that you have really excellent research here about health inequalities, and I would love to be learning from you in terms of aligning myself and Work Strand 2 here at college. So final Work Strand, how do we enable data decision making? This is about complex interventions to increase awareness and inform behavior of patients and healthcare professionals. And here I mentioned both because it's about shared decision-making. The first step would be, how do we even communicate about this? So this, I don't know if surprisingly or not, is based on a real example. It's obviously fictional, but it's based on NICE's asthma inhalers example, where they compare different inhalers to car journeys and kilograms of carbon emissions. Now, is it understandable? Does it help shared decision-making? We're not sure. This is the exciting part of Work Strand 3, is that we can really make a difference in how these conversations are done in a way that involves patients and healthcare professionals. So what I propose here is that this is about the trade-offs that we've already discussed in Work Strands 1 and 2, and also learning from the communication literature, because obviously there's people that have done this in other contexts, like, for example, environmental impact of transports. So you should be learning from those people, and then in a participatory way with healthcare professionals, patients, and other decision makers, develop communication tools to communicate about this data. And I've noticed you have quite a lot of exciting communication of data things at the entrance of the building, which I loved. The goal here is to improve carbon literacy. And with insights from behavioral science, it's then to improve carbon engagement. And what is that? It's about knowledge and intention to take the actions to lower someone's carbon footprint. The literature shows that literacy, engagement, and action are associated, but it has not been done in health services. So that would be an exciting starting point that could have a lot of impact in health services. I think this should be part of a wider conversation, though. So choosing wisely, and I mean specifically, I'm working with Choosing Wisely Dentistry in Scotland, and this is about de-implementing necessary treatments from the health services. So there's clear links in terms of making health services more efficient. And also GERT, which I have links to, and that's the NHS England initiative to decarbonize health services. And so we should be speaking to a range of stakeholders in order to ensure that this work strand makes a difference and can really be put into action in practice. I think there's lots of funding opportunities for the program, and it is well aligned with funders' priorities at the moment. So I'm going to finalize by saying that Ripple is about achieving global impact in transforming health services to serve patients and the planet in an equitable way. I think to achieve that, we need better environmental data, we need to influence global policy making, and we need to transform awareness and behaviors of patients and healthcare professionals. I think I'm in an ideal position to deliver that, given my skill set about statistics and communication of data, but also involvement of patients and the psychology of understanding data. So thank you so much for listening, and I'm happy to take questions.
Thank you very much. That was excellent. And you've given yourself 2.5 minutes more of question time, which is great, because there's fascinating things to unpick there. Go ahead.
Thanks. It's so interesting and really well presented, so well done. So I'm slightly concerned that your definition of environmental data seems to be carbon footprint. So what we're understanding now about carbon footprint is that it is a great thing to try to reduce for planetary health, but a lot of the things that we're doing to try to reduce it are bad for human health. So densification of cities turn out to be a really bad idea for health. Electric cars turn out to increase particulate matter over time, and so on. So in your complex decision making, if you just focus on carbon footprint, you might have an unanticipated consequence of making health worse. And I wonder what your response to that is.
Thank you, Rich, right? Yeah. This is my mistake, because I didn't make this clear from the start. When I said environmental impact, I didn't define it on purpose. And this is because we have not agreed what's the best measures that actually can influence decision making when we're measuring environmental impact. So I completely agree with what you just said. I don't think there's consensus yet on what we should be measuring. And when I said smarter data collection, it really is about that. We don't necessarily need to be measuring every single potential environmental impact in every single intervention. We need to come down to a set of outcomes we agree in that can not only be collected in clinical trials and health research, but also be shown to decision makers. Because I totally agree, and there's actually recent research that shows that patients and members of the public care a lot more about animal species, for example, and endangering them compared with greenhouse gas emissions. So I totally agree, and you could see from the NICE decision aid that they made that call. And I'm not convinced that it is the best call. I think there's a lot to explore there. Thank you.
Thanks, Beatriz. Yeah, I was maybe going to ask something along those lines too, because I think when we're methodologists, we have to be interested in the methodology of carbon footprint as well, because it's kind of slightly flawed concept potentially. But anyway, that wasn't my question. I was going to ask about the idea of the the patient-informed differences and the example of the bleeding gums. And maybe just to approach on broad stage a little bit, so about surrogate versus clinical outcomes. So just an example, patients may have one view about whether my gums bleed or not, may be less important than in Glasgow. Will I have any teeth? Literally, that's the level of it. So people may not realise without. It may be harder to capture those kind of long-term outcomes with those that kind of patient input than the short-term surrogate outcomes. So,
yes,
would you like to comment on that?
I agree. That's true. So basically, the idea is that we're exploring feasibility. We're going to assess how these work in practice. And when we prepared the application and developed the proposal, we thought about, is it going to focus only on patient-reported outcomes, or are we going to include clinical outcomes? And then you would go into a world where it might be about surrogate outcomes or about other types of clinical outcomes. What we concluded is that we need to be having conversations, first open the door and say, do patients care about other types of outcomes? Do they want to have a say? And if they do, you probably need a range of opinions. So I agree, or the way you present the data needs to be specific to that setting of surrogate outcomes and what do they mean in the long term. It's also linked to a very good question related to primary outcomes, particularly, which is how we calculate sample sizes, as you well know, being relevant patients. So if we choose good primary outcomes, we probably are in less trouble, although taking the point that sometimes we can't. And that's what we're exploring right now. So what we've seen so far in early work is that patients are actually quite keen to contribute to everything. So they haven't been put off by outcomes that sound a bit more complex, and we need to explore how we would do it. But we're first going to ask those questions and then take it forward and see how it goes.
First.
Thank you. It's really exciting work. So you described really nicely at the beginning how there's potential for inequalities in health to be widened. Could you say a bit more about how you'd include a sort of inequalities lens throughout the different?
Yes, sure. So basically, the way that I've thought about it is that we would have to first guarantee that we're collecting the right data. So, for example, the multi-criteria decision analysis could be used with underserved groups to make sure that we need to have the right people answering from the perspective of a diverse group of people answering to have that data. And that applies to all work strands, really, because you don't also want to have communication tools that are, too difficult to understand or something like that. So we need diversity in the recruitment process, in the involvement process. And then the idea is that when we're collecting data with patient subgroups, that we use a specific quantitative method. So there are subgroup analysis types of regressions that we could use to be exploring that. So that's the idea, is that we build it from the get-go with diversity of recruitment, and then we complete it by having the right data to be able to look at these heterogeneous effects. Does that answer the question?
Going to go and then Francis, and then that'll probably be time up, but yeah.
Thanks, I really enjoyed that. So I'm coming to global in your very last slide, so I don't want to say things there. And a lot of what you talk about is at the individual level, right? But what I hear during trials in the global south is that these trade-offs can also be hugely disadvantageous to countries. Public carbon emissions associated with drug X
a country in Africa said, well, that means we're going to get less of it, right? So, how do you overcome those global equity issues when you're thinking about it?
That's a really great question. I think we would have to do this in the context of making sure that we partner up with lower and middle income countries to hear their problems, because it might be that actually the priority in those settings is about efficiency gains. It's about how do we make research and health services more efficient. Therefore, side effect, they're more carbon friendly. But it might be that that's how we should be prioritizing it in those settings, because it's definitely not the point to create further inequalities, as I said. So, going back to that question and taking that into consideration, I think that's the starting point to answer that really challenging problem. Thank you.
Francis?
I was just building on your comment about health literacy, and I know you're talking about getting seldom heard groups, but some of our seldom heard groups kind of can't read at all, and I just was wondering how you were dealing with those who are most badges, like people experiencing homelessness, who might have quite a different view of value and cognition.
Yes, so I have the first part is that I haven't done it yet. So I have to confess that I haven't explored that avenue yet, but I'm very keen to open up as much as we can. And I think what I've seen in the literature in terms of your specific question is that using pictures to describe things is quite helpful for specific subgroups of patients. It might be that some patients don't want to see the data, and we also need to understand that. And then the decision-making goes to a different avenue. So again, it goes back to actually understanding people's needs, talking to them first to set ourselves up for success. But it's a great question. Thank you.
Thank you. We have got time for one more quick. Yep, go, Kathleen.
So my question kind of touched on maybe on what we was hinting at. So I was thinking about the kind of work package 3 and the decision-making context, and just really some reflections on whether you think and how far away we are from decision makers such as NICE and ICMC in the UK, but also in the international decision makers, how far they are away from actually, incorporating environmental assessments alongside the normal criteria, and changing the reference case and incorporating some of these things. So I just wanted to have.
Yes, so in terms of health technology assessment worldwide, I know that it's a hot topic. So if you go and check their program right now, the scientific program, they'll always have a session. In the last probably 2-3 years, I don't know if longer than that, but definitely those I checked. And so I think from that perspective, which is probably mostly Western countries, I would imagine, it is getting considered. So I have links to Portugal and Portuguese research, and I know they're starting to think about it too. So it's kind of everywhere from that perspective. In terms of lower and middle income countries, my understanding is that it's not there, and there might be good reason for that. There are quite a lot of those countries, as we discussed, that are not really, that don't have a really high carbon footprint in terms of worldwide perspective. So maybe that's not their priority, but it is definitely an international perspective on this. Yeah.
Well, thank you very much. That's perfect timing and a great discussion, and well done. Really enjoyed your presentation. Thank you for making the trip down. And yeah, we'll obviously be in touch with you soon. I look forward to reading more information.
Sounds good. Thank you so much.
Thank you.
Thank you.
I don't have any questions. Right. Yeah, don't forget your back.
No.
I just have Daniel Kopasker on as our next future fellow candidate. So what 20-minute presentation. We look forward to hearing what you say.
Thanks very much. So I'm going to talk to you about simulated trials of population level interventions to address health inequalities. So we know that every year health inequalities cost the NHS an awful lot of money, yet very little seems to change. So for example, in terms of obesity, the prevalence gap between the least and the most advantaged groups in England has been 10%, and that over 10% for a very long time. And we know that obesity costs the NHS at least £5 billion every year. So one of the reasons that there hasn't been a great deal of progress is that the policymakers haven't received actionable evidence that works across policy areas. And that is what I propose to do. I propose to use simulation modelling to address this evidence gap. So there are many barriers to conducting real-world trials of interventions that cross over multiple policy areas. The most obvious one is the complexity of those pathways. So being able to do that within a real-world trial is very difficult. There's also the cost of running these trials, so they would be incredibly expensive. It would take a long time for the health outcomes to emerge. And then also there's other ethical and political constraints that prevent these real-world trials from taking place. But simulated computer-based trials can overcome this problem. They can be run at a fraction of the cost. You can have the health outcomes very quickly from over a long period, and you can have complex pathways interacting within the model. So you can have multiple policies that interact within these simulation models. And the way that you do this is that you combine the best available evidence and data, and then you project outcomes for over this long period. And if a policymaker comes back to you and they want to change the intervention slightly, within a computer-based trial, you have that flexibility. So you can do these things. It has an awful lot of advantages. It overcomes the problems of real-world trials and can address this evidence gap. And when you do simulations at an individual level, so what we call micro-simulations, you have individual level outcomes, which supports the analysis of health inequalities. And then another aspect with computer-based simulations is that you can use observed data, or you can use synthetic data. So with synthetic data, you can start to build sample sizes that are as large as the population that you're interested in. And this overcomes difficulties with underrepresentation of certain groups within real-world trials. So there are many advantages. So here's a simplified version of the model that I propose to simulate. So this fellowship has a very strong foundation in that we have an existing micro-simulation framework that's open source, that involves the economic determinants of health. So the boxes in green are what our current framework can already do. We've published papers doing this already. The amber boxes are the things that I propose to add. So this is the extension to the existing framework that I propose within this fellowship. So we have these multiple disease areas where obesity is a common risk factor. And this is from the discussions I've had with colleagues across MBLS about how we can bring this together. And obesity is a common factor that allows us to do that. So if you consider intervention.
Oh, you could please mute if you're online. Thank you.
Okay. So if you consider an intervention that just addresses obesity, so weight loss drugs, let's say, for the unemployed. So if that was effective, you may see improvements in these health outcomes, a lower healthcare utilisation for a period. But if that person then becomes employed and that job is low paying, so they have a budget constraint, and then they go into a food purchasing environment where unhealthy foods are incentivized, that budget constraint and that environment combine so that they would have low nutrition still and the obesity problem reemerges. So just that intervention alone is unlikely to be cost effective. But if you consider the same intervention, so obesity, so weight loss drugs for the unemployed, and if you combine that with, say, an increase in the national living wage, and then also policies that affect the food purchasing environment, such as restrictions on promotions of unhealthy foods, then the initial intervention is reinforced. So, and then that combination becomes cost effective over a long period. And it's those sorts of combinations of interventions that I would look to model within this fellowship. And that requires interdisciplinary knowledge. You would need to have knowledge of economics, you need to have knowledge of simulation modelling, causal inference, and policy evaluation. I'll show you in my career journey that I've gained experience of all of these things. So I start here with just the academic career in 2017. There's also some experience from prior to that. So I used to work for an elected politician. So that gave me a good understanding of how policy is actually made and the pressures that people are under and how evidence is used in that policy making. And then I also used to work for a citizens advocacy charity that was involved in ensuring that the views of people with learning disabilities were considered when decisions were being made about their future. So I have this understanding of how these advocacy charities work. But I'll start in 2017 when I was awarded my PhD in economics. That was at the University of Aberdeen in the business school. So during the time of the PhD, I also did quite a lot of other research projects that I worked on at that time, and they all had this common theme of employment, health, and the welfare state. And then after finishing the PhD, I was awarded a career development fellowship, which allowed me to move from the business school to the health economics research unit at Aberdeen and gain a lot of experience of health economics. So this included working on the government commissioned evaluation of minimum unit pricing, which involved, so the work that I did there was looking at how a change in the price of alcohol affected the consumption of other products. So that was using product level data. And then I also worked on some nice technology assessments. And it was working with that framework that I started to gain this interest in how that rigor could be applied to wider interventions. So this led me to taking a job at the University of Glasgow, working on microsimulation projects. And a lot of my role at that time was initially using causal inference methods to populate the model, but then also I had to be this sort of interdisciplinary interface, explaining the economic methods to the public health people and explaining the public health methods to the economic people within the team. And then that helped in terms of engaging with policymakers, because I got better at being able to explain complex methods to them. Shortly after, I received a grant as the principal investigator from the Alan Turing Institute to build synthetic populations using machine learning methods. So that's something I'll come back to. Last year, I joined the editorial board of the leading journal for microsimulation, and I was also awarded an Understanding Society Policy Fellowship, which focused on examining how the impact of unemployment on health differed between different welfare states, which provides a foundation for extending our UK model to other countries. I was also involved in the unit being awarded funding by the MRC World Class Labs, and this upgraded our computing infrastructure. So simulations use a lot of data, they use a lot of memory, a lot of storage, and we now have that infrastructure in place here in Glasgow. This year, I published a paper, simulation paper within social science and medicine. Just recently, we've been awarded funding to extend the model to European countries. So I'm a co-investigator on that grant, and then I'm principal investigator on an NIHR grant that looks to bring in macroeconomic simulation within our framework. So we've yet to hear about that, but we're quite optimistic it will be funded. So I showed you the simplified model earlier. This is the actual model. I'm not going to go into it in a great deal of detail, but you see that green box that I had previously that just said income and employment. That is all the stuff that is on the left-hand side. So the framework is very good at predicting economic determinants of health. And again, the amber boxes are what I intend to add within this fellowship. And this is all open source. And we validate this model by predicting the past. So we predict from 2011 to 2019, and we compare the predictions of our model against observed data. So we know the model provides useful projections. And here is just an example of the output that the model can produce from one of our past research questions. So we were interested in evaluating an observed policy in this case, which was the government's response to the COVID-19 economic crisis, against a counterfactual where there was no policy response, which is what happens during most other recessions. So you see we have projections for the employment rate and also for the level of psychological distress within the population, and this can support policy making. So the research questions that I intend to focus on within this fellowship, I'll just go through these. The first one is, how can clinical evidence be integrated within a population level simulation to tackle health inequalities? The second, can machine learning methods detect and reduce bias within synthetic populations used in simulations? Third, which population level interventions are most effective in reducing both obesity and poverty in simulated trials? What are the costs of consequences of implementing policies to reduce obesity and poverty? And how should simulation studies be communicated to increase policy uptake and public acceptance? So each of these research questions has a work package. So the first work package is that integration of the clinical evidence. So I've had some great conversations with colleagues from across MBLS about how we can do this. So some of this evidence might be from clinical trials. Some of it may be from registers. Some of it may be just from other studies about how we can predict things better. So there's a range of evidence across these areas. And so we have heart disease and type 2 diabetes, nutrition, multimorbidity and frailty, pancreatic and colorectal cancer, and dental caries. And all of these people have agreed to be collaborators on the fellowship. The second work package is building the synthetic population. So as I said, we had a proof of concept project funded by the Alan Turing Institute, where we've managed to begin to build these synthetic populations of the whole of the UK. So we take observed data and then we expand this to a very big pool. And from that, we select the 60 million individuals that align with census targets. Now we can do this better, and there's expertise in data science within the school here that where you can have machine learning methods to detect the remaining bias within the synthetic population. And the benefit of this synthetic population is that these underrepresented groups are included in the trials. So then the third work package is actually to run the trials themselves. So you'll see here that these combinations of interventions that I've been talking about, so we have the medical intervention with the weight loss drug, we have the restrictions on promotions coming in next year, and then we have increases in the minimum wage. So these combinations of policies are happening. So this is the sort of thing that we could simulate, and we could find a way to optimize these policies such that they reduce health inequalities to the maximum extent. And we would work with policymakers to ensure that those scenarios are things that they are interested in. And all of this can be done at a fraction of the cost of real-world trials. And from that, you can identify novel combinations of existing treatments and also how that can be supported by upstream interventions. Then having run the trial, you have all this individual level data on outcomes. How do you integrate that within a framework that supports decision making? And that's an area where the health economics team here in the school have a lot of expertise. So I would collaborate with them to find the best ways to support policymakers in making these decisions. And an important aspect of the way that the model can work is that you can have variation in restrictions to healthcare access. So we know this is an issue for health inequalities. That can be built into the model. So you may have interventions that increase that access, or you may have interventions that have to work while those restrictions in access are in place. And then having put all the outcomes together within a framework that the policymakers can use, you then have to take it out and try and ensure policy uptake or encourage policy uptake. So we work with the Centre for Public Policy here at the university, who are well aware of many relevant organisations that we could work with. We've previously worked with the Poverty Alliance as well on a number of projects. We have good links to policymakers already, but we can expand that by working with the Centre for Public Policy. And then also working to ensure that the public understand these methods and have confidence in what in the evidence that's being produced by simulation. So I would also collaborate with Tracy Ibbotson here at school. So the plans, by working so closely with the policymakers on the combinations of policies that they are interested in, we think this could provide a good platform for future REST studies. I would hope to publish more 4-star journal publications. We've already had. Okay, thanks. We've already had 2 published, and so I think there'll be more. And of course, the whole framework is very adaptable. I focused here on obesity, but we can bring in other aspects where MVLS has expertise. So, in particular, the green transition and planetary health. There'd be many things that it would be possible to do there as the economy restructures. Some people will lose their jobs, some people will find new jobs, you'll have to do all that reskilling. So there's a whole economic thing that will be going on within that green transition that will impact on health inequalities. We're in discussions with the Global Burden of Disease study to collaborate on ways to get economic determinants of health within that study. So this is a wealth of administrative data that goes in to that study, and that would provide a foundation for extending the model to multiple countries. So we're already about to extend the model to more European countries. 2 of my 4 current PhD students are working on ways to apply microsimulation models in Ecuador with administrative data there. And there'd be more strategically important countries. So of course the University of Sydney, there's just been a partnership announced in terms of health inequalities. They have fantastic data that we would be able to put into this simulation. So I hope that during this presentation I've demonstrated that there's a strong foundation for expanding the modelling work that's done within MVLS. And that expansion can bring in the broad range of expertise from across the college. There are strong links with policymaking organisations, and the computing infrastructure is in place due to that MRC funding that I was involved in last year. And then there are synergies with the public health modelling projects that are ongoing within the college already, particularly Vital Katikareddy's Health Equity and its Economic Determinants project and the Health Mod project of Petra. So in summary, this is an ambitious project to build a model that links directly to policymaking priorities and is flexible to meet the changing priorities as the political landscape changes. It integrates expertise from across MVLS and would accelerate MVLS's emergence as a centre for public health modelling, which would provide substantial opportunities beyond the fellowship. Thank you.
Okay, thank you very much, Ben. That was really good. That's really clear. Questions? Rich.
That's really interesting, really impressive, very exciting. I guess one of the issues around these kind of models is, I think is it equifinality, is that what you call it? So the idea that you can, when you validate your model, the model can produce the right margins, the right outcome, but for the wrong reasons. And I'm wondering, I guess, about your ability to allow for that, to enable people to trust what you're saying. I mean, but the nice thing about a trial generally is that, you know, you've done it right, you know whether it works or not, because some people are alive and some people are not, essentially. And so how do you deal with those kinds of questions about how do you know it's right to generate trust?
Well, the validation is very important, but the validation goes across multiple areas. So you have your validation that you look to ensure that the outputs are correct, but then you can address all different elements of uncertainty. So in terms of parameter uncertainty, I mean, there's levels of prediction that is going on here. So of course, all of them are uncertain. So when we run the model, every time we take a different set of parameters from the parameter space, so we know that there's differences there. And we run the model 1,000 times, and that gives you an idea of that uncertainty. In terms of, I think what you're talking more of is the structural assumptions. So you can tweak them. You can change the assumptions within the model and see how things change. And then there's also the comparison to other models. So models being done elsewhere, done in a different way. So if what you're producing looks very different to someone else's model, then this suggests that there's a structural issue in one of the models. And then we can work very closely with people to understand those things. So a lot of this is testable. I mean, there's so much flexibility in the model there that a lot of these things are testable. So if the assumptions are questioned, we can use alternative assumptions.
Yeah, so I think I really enjoyed your presentation. I think it's super cool actually, but building on Rich's question, and so yes, we do trials, but they're very, very, very rarely powered for subgroup analysis, they're powered for the primary outcome for the whole population. And so when you are trying to make inference about, for example, the most deprived group, you inevitably, your trial estimate is hugely uncertain. And I was just like surprised to see how much precision you had in your estimate of your outcomes here. And where was that precision coming from?
I didn't interpret that as precision. So we're back here, yeah. So
for example, your psychological distress.
So I mean, look at the size of these uncertainty intervals. There's a great deal. I think that I interpret that as there's been a lot of uncertainty, and that being in, and there was so much uncertainty there that we looked at a different way of presenting it, which was to compare pairs of scenarios. So, like as I said, every time that we run the model, there's a different set of parameters that are being used. So we ensured that they were using the same set of parameters, and then compared the difference in effect between those two pairs, and then we actually published the full distribution of those pairs. So I interpret that as there being a great deal of uncertainty, and I was more concerned about how we can address that.
Thanks. Yeah, so just following up on that, I guess. So I know a little bit about nutrition, and so what you find often when you look at observational data, you see some sort of association, then you do the trial and the number is quite different, quite different, and that's why you do the trial. So a lot of this is determined by what data you have that's going into the model. Like understanding the effect of eating more whole grains, right? I don't know what it is, right? It could be almost anything depending on what's it. And if you're going to do multiple different interventions at the same time, the uncertainties will multiply.
Yeah.
And I remember having conversations with Petra, and she said, well, it's quite difficult to model sort of more than one intervention at a time because the confidence intervals will just be so wide at the end. And that sounds like it's what you're trying to do. So convince me that it's kind of following on from this, that you're going to get a value where the errors are such that the numbers are meaningful at the end.
Okay. So already we have multiple processes interacting. So when you're talking about multiple interventions, this is the same as those multiple processes interacting. So you have that uncertainty within the model. It's how you communicate that uncertainty that's the most important thing. So there's elements of uncertainty that we can test. So the parameter uncertainty is the clear one, but then also there's elements that the structural uncertainty is more difficult. And then it's about how we communicate this simulated evidence to the policymakers as well. So we don't want them thinking that this is a crystal ball. This is a projection of potential outcomes under certain scenarios. So it's about the communication of that. We're not going to try and move away from that uncertainty. We'll ensure that it's quantified. We'll ensure that it's communicated, and then we'll still be able to say the value of this, because you're in a situation where the evidence doesn't exist. And this has been holding back the study of health inequalities for years. So you can have this evidence. It may be quite highly uncertain, but it also gives some indication where currently there's none, and we can communicate that to the policymakers.
Thanks.
Thanks, Daniel.
So Kathy didn't really hands up.
Thank you. I wasn't sure.
Sorry.
Thanks, I really enjoyed that. You talked a lot about how you would use the findings from these microsimulations to feed back to policymakers about choices they might make. But you also mentioned in passing that one of the groups you would work with would be the Centre for Policy Studies, and also Tracy Ibbotson here.
Yeah.
How do you see actually bringing the public in and giving them the chance to input into the decisions you're making about this modelling that you're doing?
Yeah, so that's actually something we have experience of already. So the NIHR proposal that I spoke about, that we're waiting to hear the outcome of course, NIHR always won a lot of PPI within any funding proposal. So before when we were developing the proposal, we ran a series of workshops with people that had experience of poverty or economic insecurity. And then from that, we co-produced a systems map of how they felt that these things manifest. And that is the structure of the model, ultimately. So they were involved right from the start. They told us this is how it affects our lives. And then that becomes the structure of the model that we used in the proposal. So based on that, they have this understanding about what it is we're doing. They then also tell us, how the thing works, how they believe it works. And then we're going to go back to them at the end and demonstrate how that information was used, and then, ensure that understanding. And all the time, because everything is open source, those that have the skills, they can go and they can see how everything's working. So this is when we're talking, particularly with the policymakers, they can model, they can change things, but we have that PPI involvement at the beginning. I've also had to, so we had a health foundation project that was funded. That was this one, in fact, the COVID-19 project. So the results at the end, I took to the Health Foundation's inclusion panel, and they really gave me a grilling about what they meant and how it was done and all of these things. And I worked with a facilitator at that time to help communicate these complex ideas. And I wasn't allowed to say the word model when I was doing this. So it was really very tricky. I have some experience of doing this, of communicating these complex ideas, and running these workshops with people affected by poverty and economic insecurity, and that actually gives us some indication of how the model should be constructed in the first place.
Yeah, you mentioned quite a lot about some of your internal, especially SHW and NBLS collaborators. I was wondering if you have any existing external collaborators, or if you know other people internationally who are doing either similar things or
Yeah. So everything that we do, we work with a group at Essex who are the Centre for Microsimulation and Policy Analysis. So that's Matteo Riccardi and his colleagues. So this is one of our main collaborators. We also work with a group at the University of Leeds, so demographers there. So there's people that are very, very good in terms of building these synthetic populations. So we work there. And then the North Face project that's just been funded, that is with researchers in Germany, Poland, Spain, UK, there must be one more that I can't quite remember at the moment. So we have these international collaborators. We have UK collaborators with a lot of experience of microsimulation. And then we're also looking to move that further afield. So I talked about the discussions we're having with the Global Burden of Disease study. So that came out of it was a commentary piece that I wrote for the Lancet Regional Health, where there was a group of public health researchers from across Europe that came together to say that to encourage the greater adoption of microsimulation to address the need for actionable evidence. So some of those co-authors there are also involved in a global burden of disease study. So we have emerging collaborations and then also existing ones.
I think that's all. Go on then, Rich.
Ask this like the existential ones. So I think the work's amazing, but it's founded on the premise that if only the policymakers had better information, they'd make the right choices. Do you think that's really likely? I mean, you think about the last government.
Yeah.
They could have the best evidence in the world, but there was a different agenda, right?
That's why it's not just about the evidence. So I said about my experience of working for a politician about how messy the policy environment is, how it's driven so often by this group one day and this group the next. You know, we have to take that into account. And that's why, you know, this co-production with the policymakers to start with, finding better ways to advocate and communicate the evidence, that's a part of this fellowship. And even when the ideas might be a little out of fashion, keeping the ideas alive because of how strong the evidence is also very important. And that's the sort of the mess of the policy environment. But I think the Centre for Public Policy will have particular expertise there as well. They have this evaluation lab that they're running, and there may be some opportunity to integrate this with the evaluation lab. But I mean, improving the way that we get out and we distribute our research within the policy making community is actually one of the aims here within this fellowship.
Yeah, the policy community responds to some extent. Policymakers is a very broad church, right? But the public drive a lot of stuff because of what's just happened in America, right? Landslide victory for a set of policies that, you know, probably not very well supported by any kind of evidence, let alone simulation. So
yeah, so that's another reason why bringing the public along with this. So the public acceptability of simulation evidence is definitely growing. So you have this working with the public here. You have working with advocacy organisations who are arguably better skilled than academics at actually promoting the evidence and promoting the ideas, and then also the co-production with the policymakers. So it's not just the evidence, it's that process of the distribution of the evidence, the advocacy process also.
Thank you very much. I think that's us at time. Thank you very much. Well done. So we look forward to seeing your application in the next few days. Good luck.